Hi, everyone. I don't know if this is working. Yeah. So thanks everybody for being here. And this is Dr. Marlena. She's from the University of Melbourne and she's an implementation scientist. She's here with a group of people from the university to build collaboration between CMC and University of Melbourne. And I'll hand over now without further ado. She's also my supervisor for my PhD, and I'm really grateful to you for coming and talking to us about implementation science, which is not something I knew about till I started working with you. Over to you.
Thank you. Thank you, Tina. And I might just, if I put that there, can you hear it? Oh, that's okay. And I've got a loud voice anyway, so I can project. So thank you so much for the opportunity to come and talk to you all about implementation science. And I'll go through what it means and how it can make a difference to some of the practices. But really today, I don't want it to be just me up here presenting like I'm the expert about everything. You know your context. So I think it would be really helpful, and you get a lot from it if you ask questions, if we have a two-way dialogue. I feel that sometimes, certainly in my field and even in my last few days here in India, we have this perception of this ideal, a gold standard. I mean, I have that in Australia too. And then we have the practical, pragmatic, messy realities. And somewhere in the middle, we have to try to make things work. And I think we need to have these conversations and be able to say, we can't do that here in our context. And actually, a lot of my work is about tailoring. And it's about saying, I can't get that intervention to work in Alice Springs because I can't get the right resources. So how can I get something that will work in a resource-constrained settings? So I really want you to keep that in mind. And even if I'm going through some things that feel like it's unachievable, I want you to hold in your mind that we do a lot of tailoring, we do a lot of adaptations, and we think about how we can get this into any different contexts. So I feel like we need to start with that caveat. And if at any time you want to ask a question, I give you permission to interrupt me. Please don't wait to the end. Just say, hey, can you just go back over that? Could you explain that? Because I'm sure that if you have that question, everyone else would have the same question too. Okay, so I'm sorry, you've probably seen some of these stats, but just for anybody else who in this room hasn't had the pleasure to read this paper by Ballas and Boren, it's an estimated median time of about 17 years for research, and we're talking level 1 research to become routine clinical practice. And that holds true, doesn't matter where you are in the world. It's perhaps expanded or even tougher in some settings, but it is on average about 17 years. And we know that there are lots of contributors to that. And it's very rarely about us as clinicians not wanting to do the right thing, and I'll come to that in a moment. But we tend to group it in these 5 sort of areas around these contributors to the care gap. So we know the evidence is out there, but often it's very slow for us to get those interventions into practice. I know my colleagues who work in general practice in Australia, that field, the evidence is shifting so rapidly. It's really hard to keep up. You're seeing 20, 30, 40 patients a day, and then you're having to try to keep up with rapidly moving evidence. So that contributes to that slow uptake. We get a lot of unwarranted variation. So not to do with person-centred care, but to do with if you present to one hospital in Australia, you will get a wildly different intervention, even for something as standard as stroke care that is very driven by guidelines, as what you might get in a metropolitan hospital. So unwarranted variation, a really big issue in Australia. Ongoing low-value care. So that's things, for example, where the evidence has shifted, but we're still doing the old stuff because we're not aware the evidence has shifted. Or what I see increasingly is that we jump to put something new into practice. So there's early uptake of something that we don't know that it works yet. Sometimes there's rationale for it, and sometimes it's premature and it's a bit too soon. But I don't want to say it's always a bad idea because there might be some emerging evidence around it. So that can be a little bit controversial. And I mentioned before, it's hard to keep up with rapidly changing evidence. There's a cost to not being able to deliver evidence-based care. So there's a cost for all of us, and there's been lots of research on this. And I don't want to harp on this too much, but there's a big systematic review in America who have a really terrible healthcare system. And they really certainly struggle with evidence-based care as well. And if we look at that chronic care space, which is really a lot of what we do in general practice, in these studies, in this systematic review, which I think it included something like 500,000 patients in total, they found that in 20% of those studies, patients received contraindicated care, so care that was actually harmful. And in 20%, they received low-value care, so care that just wasn't helpful. Might have even been damaging, but certainly wasn't helpful because the evidence had shifted. So we're all kind of battling with these same sort of problems everywhere in the world for different reasons. These are some of the care gaps that I'm working on in Australia. So just to reassure you that I'm working on similar problems perhaps to what you're seeing here. So I have a great colleague, I was speaking to Tina about this earlier on, where we do very badly in penicillin allergy testing. And for some reason, everyone thinks they're allergic to penicillin. And that's a real problem for the world, right? In terms of penicillin allergy. And we've been doing a lot of work to see if we can get better routine penicillin allergy testing and delabeling in Australian hospitals. We're into our 3rd year of that study and we're making gains, but oh my gosh, it's been hard work. So, these are failure of care delivering. So we're not routinely doing penicillin allergy testing. Falls prevention program with people who can't speak English. They just don't receive it. Our middle class people do, but our cold populations don't. And they have a very high rate of falls and they have very poor outcomes. So they have a higher rate of morbidity and mortality. And so we've got a really big project looking at that. We don't do routine frailty screening. And that's a problem for us because if we don't do routine frailty screening, we can't match up the interventions. Overtreatment. We overprescribe antibiotics. We had that discussion as well earlier on. We're still stuck in that same cycle. We give a lot of our patients non-slip socks. I'm not sure if that happens here. It's a nice thing to do because everyone likes to receive a little pair of socks, but it does not reduce falls risk and it actually harbors bacteria. And what a waste of money. And I've been spending 3 years trying to get hospitals to stop doing that. And it's a waste of my time too. So, that's another example of low value care and a real waste within the system. And I'll just tell you a very quick story about these non-slip socks. I had presented for a small surgery. And the nurse took me to my room and gave me my surgical gown and all the rest of it. And she gave me the non-slip socks. And I said to her, oh, no, we don't do that. Like the evidence has shifted. I don't need that. And she said, but I have to give it to you because what else will I do? And she was really quite upset. And I didn't want to upset her. So I took the socks and I thought, I just don't want to upset her anymore. So I'll take the socks. So changing practice and getting people to stop doing something is wildly difficult. And that's a really good example where a nurse said, but what will I do instead? If I can't give you the socks, I'm a nurse and I need to treat you in some way. So we're doing a lot of work around de-implementation, which is a different lot of strategies to implementation. So, these areas, this is not controversial. These are areas where the evidence has been there for a really long time. So it's not a problem with knowledge. We all know what the right thing is to do. And yet we could see these persistent sticky problems, these persistent gaps across the world, which tells us it's more than just what we do or don't want to do as clinicians, that there are systemic issues that can either support or hinder our ability to be able to deliver evidence-based care. And of course, we've known for a long time that we've got these problems, and all of us across the world are trying our best to be able to reduce that gap. And things like CME, your continuing medical education, or your CPD activities, extraordinarily important. We have to start with knowledge, because without knowledge, we can't progress at all. So that certainly had some impact. Clinical practice guidelines and policies, also very important to have some guidance around what to do. But despite having these strategies to help us reduce the gap, we continue to witness and see these gaps. So much so that I think this paper was 5 or 6 years ago, it was written up in the JAMA, and it was around looking at what's changed since we've had this concerted approach with guidelines and CPD and CME. And the authors here just declared that despite these key improvement programs, we're not seeing it reach our patients. In some ways, it's reassuring to know it's not just us, but in other ways, it's a little bit depressing to think, well, what are we going to do about this? Oh, what are we going to do about this? Implementation science, what a segue. And that's where my field started. So about 30 years ago, there was this great paper written by, who would say is the grandfathers or the starts of the field of implementation science. And in this paper, I think one of them was a GP actually, and the other one, a general practitioner, and the other one was an intensivist. And they said that particularly in hospitals, most QI, quality improvement and quality assurance initiatives, are actually initiated by, hospital heads and whoever else, or maybe from the government. But they very rarely draw on the empirical evidence that comes from organisational psychology or social psychology, despite the fact that we know that those fields can tell us how to change behaviours. So they argued in this paper that we must match evidence-based medicine with evidence-based implementation, and that we can't just continue to innovate and create these great interventions and get these great outcomes if we can't actually find a way to get it into practice. And that was essentially where the field started. So that's 30 or 40 years ago. So what is implementation science? In a nutshell, it's methods. I'm what you would call a methodologist. So we look at ways of bridging that 17-year gap, or thinking about if somebody's even starting to develop an intervention. I spend quite a bit of time in that early phase of the research translation pipeline to go, what do we need to know about that intervention that might help us sustain adoption later on? So it's about the scientific study of methods to promote the systematic uptake of research and findings into routine practice so that patients can receive evidence-based interventions. And we have our own journal. There's a few journals which actually has quite a high impact factor. It's actually really hard to publish in that these days. So that's what implementation science is. Implementation practice is not the same as implementation science, in the same way that clinical practice is not the same as clinical research. You need the both. Clinical practice is informed by clinical research. Implementation practice is informed by implementation research. So implementation practice, I have no doubt that everybody in this room is involved in implementation practice. So that's where we introduce a new clinic to improve what we're doing at the hospital and to improve outcomes for our patients. It may or may not draw on implementation science methods. It may or may not last. It's important, and we all do it, and it's part of our everyday work. It's even better still if we can draw on implementation research as part of implementation practice. So that's just to tell you, a lot of people go, well, I am implementing things in practice. Yes, you are, and you're probably doing, and I don't doubt that you're doing fantastic work, but implementation research is more about the scientific methods around how to get something to stay in practice. And this is just a PICO table around how implementation research differs from clinical research. So there's a couple of things that I'm going to show you today that I really want you to hold on to. And this is one of these things, because people can get a bit confused between, well, what's the difference between the two? Clinical research, we're looking at the effectiveness of a drug or an intervention. Implementation research, I'm looking at the effects, and we do look at effect sizes of an implementation strategy. So the population that I'm interested in is clinicians and hospitals and organisations. Sometimes I'm even looking at school settings. Whereas clinical research, we're looking at specific patient groups. The interventions that I look at, the implementation strategies, are things like audit and feedback, education, computer prompts, those sort of strategies that can influence whether we do something or not. And the outcome that I'm interested in is, did we get to deliver the intervention? There's other outcomes we look at, such as acceptability. Those are important, not as important as adoption, because what if you have something that's really acceptable but practice doesn't change? I sort of think that's a bit of a failure. We need to, that's for me the most important outcome. Did we change practice? Are we delivering the interventions? Are our patients receiving the interventions? So when we're talking about practice change, someone somewhere has to do something different. And sometimes we don't like that. People don't really like to do a lot of change. So practice change equals behaviour change. So implementation research means somebody's going to do something different somewhere. The organisation, the system, something has to change. And doing things differently means behaviours change, whether it's an individual behaviour or a systems behaviour. And the evidence base needs to draw on theories and frameworks that come from the behavioural science field, because we can predict. We've got enough data to know that how people will respond in certain situations, whether it's a patient or us. Humans essentially behave in similar ways. So my field has too many theories, models, and frameworks. Whatever you do, don't try to look at all of them because you will just be very bored. There's about 165. There's probably more because I haven't looked at this data for a few months. I don't think we need 165 frameworks. Nonetheless, we have 165 frameworks. The majority of those are what we would call determinant frameworks. I'm going to show you a couple that I like. And the reason I like them is because you can use them quickly. You don't need to be, have a master's degree in implementation science, and you can use them leanly, because you don't want to be asking, hours of questions. So determinant frameworks, they're the sort of frameworks that help us understand why somebody's behaving in a particular way. So it's barriers and enablers and things like that. The next most popular is process models, and they're lovely because they can take us step by step through how to do implementation research. And I'll show you my favorite one that I use with all health professionals in all sorts of health services. And then the next most popular one is strategy frameworks. So where do you begin? Let's say you want to introduce a multimorbidity clinic, or you want to change practice. Maybe it's your team's practice. Where do you even start? Because sometimes that feels like you're going to climb a big mountain. It's like, where do I even begin with this? And you often don't have time either. I come from a health setting, a trauma tertiary service, not as busy as this one. Nonetheless, it's very busy. And it was not unusual for my boss to tell me within 24 hours that I'd have to set up a clinic. The government's giving us money. Quick, set up a clinic. So you don't always have a lot of time to be able to think these things through. So I want to show you a process that is, it's deliberate and it's considered, but it's not resource intensive about where you can begin with your challenge to change practice. There's generally two approaches. The first one is starting with your problem. Your problem, say, might be around patients aren't receiving this or we're not delivering this. The second approach is starting in the health service. I often do both, but this is probably the most familiar one. It'll be one that you're familiar with, Tina, and probably many other people here. So there's this great paper published some time ago by Simon French, and he published this to help all of us who are working in health services and we want to change practice. And he said, how can I make that simple? And we call it the 4 steps to support practice change. That's all it is 4 steps. And it is wonderful. I'm not saying it's the most simple thing, but at least it gives you an iterative approach. So the first thing that we need to think about is who needs to do what differently. And it's really important to spend, even if it's just 5 minutes, thinking about that. And oftentimes it's more than one person. So I'll give you an example. When we think about hand hygiene and we think about how can we improve health professionals to do hand hygiene, they might be our target person for that, who we want to change practice. But we also need to make sure that we have hand sanitizer in the gel dispensers. So we need to think about whoever's filling up the gels, because I don't know about what happens here, but certainly in Australia, I cannot tell you, even during COVID, during the worst pandemic, you would go to a ward and everyone knew how to do hand hygiene, but there'd be no gel in the dispenser. So when we're thinking about who needs to do something differently, think about your primary behaviour being the clinicians, and also maybe think about a secondary behaviour. So and I'll show you an example. I've got a hand hygiene example. You don't want your idea to fail just because somebody can't find a form. It's simple things like that. It's the devil's in the detail is a saying that we have. So it pays just to take a moment to think about who needs to do what differently. And of course, I said before, we've got frameworks for everything. We've got this lovely framework that tells you how to work out who needs to do what differently. So we use this saying ACT, where we think about what the action is, what is it that needs to happen differently, who are the actors that are involved, so who are the health professionals, who are the patients, where should this behaviour happen, when should it be happening, and to whom should this behaviour be happening for, so which type of patient. So let me take you through this. So we use this a lot, and there's a lot of publications in implementation science about how to get compliance with hand hygiene. And I mentioned before, the primary behaviour that we're interested in here is increasing compliance with hand hygiene steps with using routine use of alcohol-based gel. So the main people we're interested in is the staff physicians, the nurses, the residents, whoever else. Should be happening in a patient room, should be happening before and after we touch a patient. And the target is that, we don't want to touch a patient unless we've done this behaviour. The second action that we need to be concerned with is making sure that the gel dispensers are checked and refilled. So we need to make sure that the cleaning staff know to do that. I don't usually look at more than 2 or 3 behaviours, but it's just for you to keep at the back of your mind if there's anything else you need to tick off your list to get that practice change happening. So the second thing that we look at is how do we know what's going to make somebody deliver an evidence-based practice? What things influence whether we do something or not? We have so much good empirical data on this now. Funny thing is, humans are unpredictable but very predictable at the same time. And it's really good if we can draw on this. We don't want to reinvent the wheel. We want things to be as easy as possible. And probably most of our publications in our field are around understanding why people do or don't do something. Understanding that I know I shouldn't eat a lot of sugar. My knowledge might be there, and yet there are other influencing factors. My family expect me to. They're peer pressuring me. I don't really know what the impacts are of my diet. So I don't have, the right belief in consequences. So let's look at some of the frameworks that tell us around how to identify what factors are influencing behaviour. These are the 4 most common frameworks that we use, and I'm just going to show you the one in particular that is easiest to use in a health service. And you can keep these slides, I'll share them, because they do slightly different things. So the COM-B, which is the one I'll take you through, it's really good because it can help us understand not just why an individual clinician will do a behaviour, but also a team or even a whole hospital, a whole unit, a whole ward. The COM-B includes the theoretical domains framework, which is highly published, and that looks at lots of different areas around individual behaviours. And then we've got some other ones there that you can look at if you're interested. That last one there, the consolidated framework of implementation research, is very useful if we're interested in the organisation and also the political setting. So that one's a very big framework that tells us it's not just about the people in the setting, it's about policies, guidelines, government funding, etc. And that's something that Tina's got some growing experience in using, the CIFA. I like this one because it's very easy to use. This is called the COM-B, and it just essentially says for a behaviour to happen, whether it's a patient or whether it's ourselves as clinician, for that behaviour to happen, we need to be capable of doing it physically and psychologically. So, if the behaviour we want is for me to dress myself independently, I've got to be able to bend down to put my shoes on, for example. So I need to have the physical capability. I also need to have the knowledge, the psychological capability. So clinicians, if you don't know how to deliver an intervention, you're not going to be capable of delivering it. I need to be motivated. I need to want to do it. If I don't want to do the behaviour, and we see that a lot in our patients, right? We can see some real amotivation in trying to get them to do something different. I also need to have the opportunity. So I mentioned the example before. Maybe I'm motivated and I feel capable as a clinician, but I can't find that machine. So I don't have the opportunity to do the behaviour. So it's a very simple model, drawing on a lot of psychological theory. Here's an example in the space of diabetes management. Capability. So do our patients have the ability to do finger pricks, for example? I've had quite a few patients talking about they have impaired sensation. So that's really quite tricky for them from a dexterity point of view, as well as, ongoing difficulties. Psychologically, do they understand the relationship between food intake and their insulin levels, or their blood glucose levels? Do they have access to healthy food? So you can see it's a pretty straightforward way to think about what factors will influence a behaviour. And we can get that data using surveys or interviews. So now that we've worked out why people aren't behaving in a particular way, we might have identified the top 3 barriers. This is where the magic happens. We start to say, well, how do we change behaviours? How are we going to change our patients' behaviours? How do we change clinicians' behaviours or health system behaviours to do something more regularly, to more routinely do penicillin allergy testing, or to stop giving out socks? What is it? What strategies can actually change behaviours? And again, we have some really good empirical evidence there. And we know which strategies address particular barriers. So there's a particular resource I'm going to show you in a moment. And that's the second area that if you remember nothing but that, I will have achieved something today. It would be really good. So these are the three most popular frameworks that we use around behaviour change. We've got the behaviour change wheel, we've got behaviour change techniques, and we've got expert recommendations. And the beautiful thing about all of these is that they map onto those other frameworks. So if you've used the COM-B and you've gone, I've got low capability, you just need to look up the strategies for capability and it tells you exactly what to do. Sounds like magic, but we always have to do a bit of tailoring, and I'll talk about that in a moment. So we have an online tool because in our field, there's a strong push for things to be as accessible as possible. Nobody wants to gatekeep any of this information, so it's free to get this information, and it's updated, so it's live. And as we generate more information and more data around practice change, it's uploaded into here. So it's the Human Behaviour Change tool. And it shows you, wherever it's green, where there is evidence for a strategy. So let's say, for example, that we see BACA. Let's say, for example, that one there, that's about beliefs and capabilities. Let's say that we interviewed our clinicians and they said, look, I know that I should be evaluating the diabetic foot or assessing the diabetic foot. But I just don't have the confidence. I haven't done it since my undergrad time. I'm not sure really how to do that. So that we know they've got low belief in their capabilities. Maybe they've been trained. They might have the skills, they're just not confident. So belief and capability is about your confidence. Skills, you can have skills, but confidence is a little bit different. So we say, okay, we've got a problem with beliefs and capabilities, and this tells us that there's strong evidence to instill a strategy around problem solving to change beliefs and capabilities. Similarly, if we've got low intention, so that's where our clinicians say, I really don't think I'm going to do that practice at all. You might want me to do it, but I have no intention in the next 7 days of doing that behaviour. We know that goal setting, and we see this with patients all the time, goal setting with patients changes their intention, which changes their behaviour. So this tool has all sorts of barriers and enablers across that top line. I think it's got something like 18. And then on the left-hand side, you've got your strategies. So all you need to do is go in there and select a few strategies, wherever you see the green box. Where you see the yellow one, it tells us there's some research there, but it's inconclusive. And then there's quite a lot of blue boxes where we're still working on generating the evidence. Yeah, please. Yeah.
Does it tell us what exactly that means? Like, we do mean by
Yes.
problem solving for the...
It tells you, it defines it exactly, and it takes you to the papers where it shows you the methods. I really love this tool. And like I said, if it's one thing that people go, I'm going to look that up. I think you register your email, but that's just so that they've got your email and then you can access all of it. So it defines it. And then it'll tell you, what it is, but you need to still do some tailoring for your settings, because you need to keep in mind that a lot of this information is generated potentially not in the India context. So you will always have to tailor to your context. So you might look at that and go, okay, well, that makes sense, but in this context, we might have to do a little bit of this and that, which we know, and you'd know from your systematic review as well how important that is. So we also need to measure our outcomes because we're, scientists. So how do we measure the outcomes to know, did this work? Did this implementation strategy actually mean that our patients got that care? The clinic was successful? How do we do that? What is a way to do that that's robust? And it's not just about papers. We want to know that what we're doing is working as health professionals and as scientists. So there's lots of publications around what we should measure. Sorry, that's gone on. Let me just... Yeah, lots of publications and frameworks as well about how to evaluate outcomes. And what we know increasingly is that there's a couple of predictors. So along the way, we want to make sure, I mentioned before that acceptability, for example, is really important. On its own, it's not enough, but it's a really good indicator that if your patients and your clinicians find this acceptable, your new multimorbidity clinic or whatever it might be, you've got a much higher chance of that being adopted into practice. And then the actual outcomes that we should be measuring at the end of our trial or our pre-post, and I'll go through some study designs, is adoption. Are we actually delivering the healthcare intervention? Fidelity. Are we delivering it as we intended? Or are we delivering it differently? And maybe that's okay. We need to collect adaptation data as well. How much does it cost? So I'm not sure how big health economics is here, but it is important to to also be looking at, is this viable? Because health economics tells us a lot about feasibility and sustainability. You know, we want to know if these things can stick in practice. I have a lot of concerns. We conducted a systematic review where we had 250 odd papers in that review. And of all the healthcare interventions, and I looked at all sorts of healthcare interventions. So in those 250 papers, only 9% of them, of those interventions we looked at, had sustained beyond the pilot period. That's not to say that perhaps it happens and it's not published, but of the publications that we saw, 9% had sustained beyond the trial period, which tells me that we need to be thinking about what informs sustainability. It's not enough to say something's feasible. It's not enough to say that the pilot works, because we had data from all of those studies to say it was feasible. So people were able to prove that it could work, but it just didn't stick. So we must be looking at sustainability data and why things aren't sticking. Is it because maybe it's the right thing not to stick? Maybe the health service has changed and we need to phase it out. But a lot of the times that's not the case. There's other things going on. So sustainability outcomes, I always include that as a regular.
What I understand is traditionally intervention science focuses on these outcomes. So how well particular evidence-based intervention or a practice is implemented. What I'm not seeing here is effectiveness or utility of the intervention itself.
Yes.
Now, what do we do if I have an intervention in mind that I want to implement, but there is not yet enough evidence about its utility or effectiveness? I've
got a solution for you right here on this slide, because this is my favorite topic. And I do a lot of work in these areas, and this is such an exciting area. And thank you for asking that question, because almost all of my research is in, almost all of my study designs are a hybrid approach. So we need to be really smart and opportunistic, as you said. Like maybe we've got something new and we're still testing, is it effective or not? But we can at the same time ask some questions in a secondary context, such as for later implementation, what are the barriers and enablers? And I cannot tell you how many hybrid type 1 trials I've got going on at the moment. And our argument, this is still to be proven, but our argument is that 17-year odyssey, which is probably more likely about 30 years, can be reduced if we're smart enough in a type 1 to go, if this is effective, we'll be ready for implementation. We're doing a lot of this in diabetes as well. And I have to tell you that I'm doing, and I often call it pre-implementation, as early as lab studies. And this is kind of unheard of, because my field's normally all the way on the research translation pipeline down the other end. But increasingly we're saying, well, if we're doing some testing in the lab and we've got a sense, this is around drug development, but we know that adoption might be affected. So mRNA vaccines, a perfect example. Everyone thinks I know everything. When I say everyone, consumers. You think in the COVID pandemic, we had a lot of stuff coming out, a lot of poor compliance because people didn't understand vaccines. So where we're doing more lab work, we're actually going out to see what is it that people think it's about, what do they need to know so that we're prepared, once the vaccine or whatever it is that we're developing, we're prepared with the implementation strategies. Such a great way to do it. Remind me also to send you a paper which tells you step by step quite clearly when you should do a type 1, when you should do a type 2, and when you should do a type 3. So hybrid type 2 is we power for both. We power for the primary aim of the clinical effectiveness, but we also power for the implementation strategy. So here we already have some evidence that the intervention works, but not perhaps quite enough. It's not like we might have an overview of reviews. So we're still trying to get some evidence. But we're also pretty confident that it's going to work. So at the same time, we're going to look at feasibility or the effects of an implementation strategy. I'm going to show you in the next few slides some of my studies where we're using these hybrid designs, and I'll talk through how we're doing it. Excitingly for me, I've got quite a few hybrid type 3s, which we hadn't done in Australia before. So hybrid type 3 is where the evidence is so strong. Like we know, for example, lifestyle interventions, for patients with diabetes, we do not need to keep proving that it works, but what we have is an implementation failure. So we are just not able to deliver the information consistently. It could be penicillin allergy testing, and I'll show you some of the trials that I've got here in this space. It's not sticking for some reason. So we shift to the primary aim being the implementation strategy, and often we do a randomized control trial around that. Wonderful, enormously expensive because we need very big sample sizes. Powering for that. So one of the ones that I've got, probably not big sample sizes by Indian estimations, but by Australian estimations, we don't have as many people going through the hospital. But one of the ones that we're starting shortly, in order for us to be able to actually show an impact, I needed to have more than 900 patients come through, which is big by Australian standards and bigger than most RCTs. But for implementation, that's what you need. So increasingly popular, almost all work that I'm involved in will do both, because we want to be opportunistic around learning things at each of those stages. So here's an example of some work that I'm doing, both hybrid 1, 2, 3. So the first one is a hybrid type 1. I'm working with Peter Hudson on this telehealth delivery of cancer care for terminal patients and their carers. And what we've done is we've looked at this program called Focus, which is well established in America, and it has some efficacy data over there, but nothing in Australia. And also we had to adapt it a lot for the Australian market. So we really needed to test effectiveness again. So in this trial, and we're nearly finished this trial, where it's a hybrid type 1 implementation trial. We've randomized patients either to the Focus or to standard care, and we've powered the primary outcome. I think it's quality of life. I need to double check it. At the same time, I'm collecting data around acceptability of the intervention and barriers and enablers to the intervention. So we've, as well as a digital health evaluation, is it okay to deliver this type of intervention by digital health? And we've published that protocol, so it'd be good for you to have a look at that. The second one, we just published this, is a type 2. And this is with my colleague, Jason Tribbiano. So this is in infectious diseases. I was talking about the penicillin allergy testing. So we've rolled out a really large international trial. I think we've got something like 60 sites. So it is really big. It's a very complex trial. And we've got 2 primary aims. The first one being compliance with a penicillin allergy testing protocol. And the second one being the effects of an audit and feedback strategy on complying with using that protocol, the digital health protocol. So we're looking at both of those, and we just published that. So that'll be really good to have a read of how we've done that. And then the third one, we've got 2 type 3 trials, one that's more complex than the other. This one's a little bit more simple, where we've taken an intervention that's very basic, very straightforward, has a high level of evidence. We're implementing it into Australia, and we're doing a type 3 design where we're doing, essentially, it's like a step wedge cluster control trial, almost like a bit of a pre-post. We're doing a lot of adaptation work with this, but the primary focus is on whether we can actually get people to deliver evidence-based care to patients who have Parkinson's, and this is in regional and rural Australia. Haven't published that protocol yet. That's very early. We've only just got the grant for that one. Okay, and I'll whiz through this because I probably don't have too much more time, 10 more minutes, I think, or 5 more minutes. And I think I've only got 2 more slides. Another thing that, and I'd be really curious to hear from you all here if this is something that you use. We have a healthcare system that is ideal to act as a learning healthcare system. So we think a lot about the healthcare system. It's got its own ecosystem, right? And we can do a lot of research, in particular implementation research, not starting with the problem, but actually starting with the health service. So there's been some great papers that have talked about this notion of an implementation laboratory. Essentially, a hospital is an implementation laboratory where you can try these different things and keep testing them. So the essential features of an implementation laboratory is that a research team, wherever that is, CMC Vellore, probably a good example, where the research team from the university partners with a hospital, with a health service. You use randomized evaluations, and they're embedded into your existing quality improvement efforts. And you keep going around and around in that way. So you test what's effective. In many ways, it's like, I don't know if anybody's involved in adaptive platform trials, yeah, where you're testing the effectiveness of often it's drugs. And you, as soon as you know it's right, you introduce the next thing. You can absolutely do this with person-driven interventions. There's no reason we can't be trialing that as well. Yeah, so it essentially acts like an adaptive platform. And they all contribute to this notion of a learning health system. And essentially a learning health system is where the health service continues to learn from what it's doing and it continues to adapt. It uses data that we collect routinely. Our medical record data, we can draw from that. You do your change, you check your medical record data, have we achieved a change? So we're increasingly seeing, certainly in Australia, and mind you, we don't have routine electronic medical records, just in case you think we do, we don't. We still do a lot of paper records. It's very bizarre. But, you know, particularly for health services that have an electronic medical record, we can absolutely be driving practice change using that. And these are some examples of things that we do within a healthcare setting that can really improve our practice. Audit and feedback has the strongest impact on practice change. 4.3% increase in compliance of desired practice, and often that's guidelines. The interquartile range is huge, which means we don't exactly know how it works, but we know it works. We've still got to unpack how it works. Printed education materials, and that's particularly things like printed guidelines. We also know that that can improve practice. On-screen point-of-care computer reminders, really great for general practice. And that's those things like if you're going to prescribe an antibiotic and you get a prompt on the computer to say, don't forget to do A, B, C, D. So that results in a 4.2% improvement in practice. So these are implementation strategies that can be driven from the health service to learn from what's happening and improve practice. Both have their strengths and weaknesses. Approach one, where we start with the healthcare system, it's often small scale. It's really hard to generalize, which means it potentially has low external validity. Sometimes we don't care because we're only interested in our health service. I care because I try to scale things up, but it's often the cheaper option. Approach two has a lot of, starting with the health service, you can work at scale. There's no sampling bias because you're just looking at the medical record. Arguably, it might have higher external validity. However, I'm not sure about you guys, but our medical records are messy. Even the electronic ones, the quality of the data, really bad. Sometimes we write all sorts of nonsensical things. It's getting better, but sometimes it can be hard to extract the data that we want. Last slide. If you take nothing from this slide, from the presentation, except for the two things that I talked about, maybe three, the hybrid designs, the online tool, but the importance of just taking a moment to say, well, what is it that I want to change? What is this implementation question? Talk to your stakeholders. Changing practice is really hard. So getting a sense of how people are feeling, why they're feeling that way, get your stakeholders on side. Some people carry a lot of power and they can do gatekeeping. So we need to have those conversations. Collecting data, I think we're all good at that. Developing solutions that are implementable. It's okay that we're not going to do gold standard. Let's just go for what we can achieve. Take an iterative approach to it. Sometimes that gives you momentum. Isn't it nice to get some wins on the board? That's how we got our penicillin allergy testing to work. We started small, we got some wins on the board, and then it just caught fire. But don't be fearful to start with what we call low-hanging fruit, just to get some momentum and then continue. So I think it's important to set an implementable solution. And of course, let's share our findings. I just wanted to add, I don't have this slide here, and the reason I wanted to say share your findings, particularly when you're doing implementation, I did a quick look at the literature in the last few weeks around implementation research, and I was looking at diabetes, and less than 1% of all diabetes research has anything about implementation. All the rest is drugs and whatever else. Perhaps even more concerning is less than 3% of that research happens in the Asian continent. It's all in Canada and America. So, sharing our findings, particularly from these settings, helps us change the status quo. Because I would argue that the things that are working over there are not going to work here. And we need to establish that evidence base in the same way that in Australia, we have to establish an evidence base to do with Aboriginal people, because what we're doing over there is not working either. So sharing your findings around implementation research in your multi-morbidity clinics or wherever else you're doing it is so important, because we're just not seeing enough come from these areas and we need to learn. So that one's, more important than just publishing's fun. We all like to publish, but it's more about that we just don't know what is or isn't working. That's it. That's my team.